So let me start by saying thank you to everybody for carving out an hour on a Friday afternoon to talk about data. We are so excited to introduce some of our clients for this and talk about some of the interesting data strategy uh, workflows and kind of components that we think are important for behavioral health providers. So welcome to Insight to Impact. I'm going to start by giving everybody a chance to introduce themselves with Rochelle Conway.
Hi, everybody. I'm Rochelle Conway, the System Administration Manager for the Omni family of services. I am the data steward of our EHRs and several other systems utilized by the Omni family. I've been doing system administration, which also includes project management for over 15 years. And I'm happy to share a little bit about our data journey and the insights that we have gained along the way. A little bit about Omni is that we are a multi-state human services agency, and we focus on foster care, behavioral health, community-based services. And we're currently located in Tennessee, Kentucky, North Carolina, Indiana, and Ohio. And just real quick information about our why. In 2021, we were informed that our EHR we were using for over 25 years was going to be sunset. So after that initial shock, the first thought was finding a new EHR. And of course, we had over 25 years worth of data that needed to be moved. And unfortunately, we didn't have the option of using the old system as a repository to store our data. For foster care alone, we were using two systems, one for foster care documentation and another for foster home recruitment leads. So our search meant looking for an EHR that could eliminate the need for two systems and allow us to house both foster care and recruitment. We looked at our compliance and quality, and we needed to have access to our data when subpoenaed for court or when requested for audit. And we also needed to make sure it was stored securely. So centrality of our data and connectivity to our data were two of our major challenges. One of the things,
Couple of simple ones, right, Rochelle?
yeah, real simple. One of the things that Rich talked about was our data being unique. You know, what makes your data unique? And what I said to Rich was that I don't believe our data points that we collect are necessarily unique. State regulations require all agencies to collect data from foster parents, whether that be daily notes or as proof that we're providing services for billing. It's the fluidity of the data and the story that it tells that I think is unique. And having our data centrality and connectivity helps us to see that story in a timely manner so we can help drive positive outcomes.
Awesome. Next, hand it over to Leanne from Phoenix House.
Yes. Hi, everybody. My name is Leanne Chiappone. I am the Vice President of Patient Access at Phoenix House. I've been with Phoenix House for over 13 years. For those of you that don't know, Phoenix House has been providing substance use services for over 57 years. You know, our biggest why, you know, we've been working to really broaden our data strategy to become a data-driven organization, but to really try to have all of our data sources in one place. We have many different connectors, and we want to work to bring all of that data in one place, you know, multiple different dashboards. So we have our EHR system where we have data census, you know, we track completion rates, discharge reasons, clinical trends. We also utilize our Paycom, which is where we have, you know, our payroll and our HR. We track hiring, terminations. In Contact is our current call center vendor where we track call volume, call dispositions, length of call, all sorts of things. And our OS Ticket is our ticketing system that we use internally, where we can also track all different types of tickets, whether it's facilities tickets, IT tickets, but it's really helpful to be able to track same thing, trends, you know, what type of tickets are being put in, how quickly tickets are being closed, is one facility, you know, seeing more tickets than the other. So it's it's really about what we're doing with the data and what what different things we can track to be able to see where where there are rooms for growth or where we can improve on things. So what makes our data unique? And we're going to go into a little bit more detail about this later, but we have changes in level of care amongst our residential program, and we have some challenges in being able to track that in our current EHR system, and I'll get into that a little bit more later. And same thing with our aftercare program. It requires us to track unique data post-discharge to be able to, provide different outcomes. So we'll get into that more a little bit later to define really what that means.
Awesome. Thank you. Amy?
I feel like everyone had more prep than I did with you, Rich. Amy Platt, I'm the Vice President of Data Strategy and Analytics at Well Life Network. I've been with the company about 18 years now. I'm actually coming out of operations where I was running 4 outpatient addiction recovery clinics, a prevention program, and a mental health outpatient clinic. So this is a very different role for me than previous, but basically we've been doing a complete overhaul to both EHRs that we currently use and trying, like everyone else, to bring our data into one source of truth so we can track those trends. We can get metrics that we need for grants, for programming, just for strategic planning in general. So that's been our why, is that we have multiple different types of programs, from housing programs, ACT, PROS, not just the programs that I was previously facilitating, children's programs, and they all have different needs, all have different metrics that they're trying to capture. And again, we're just trying to bring everything into one source of truth so we can actually get those measures and have the tools and resources that we need in order to do the data analytics.
Seems like the programs always grow too. Like there's always something new.
There is always something new, and we're opening 2 more clinics in Nassau County. And as we continuously expand, we continuously see that the need to understand our data becomes more and more important and more critical for the decision making.
And it was this year that you made the upgrade to the NX version of Avatar 2?
Yes, it is. We started that project in March, and we converted the entire organization from My Avatar Classic to My Avatar NX in September. We wrapped that up.
I'm sure it wasn't that busy of a couple of months.
It was really slow. It took off a lot. It was fine. I feel really well rested too.
Perfect. And Mr. Bazile.
Boy, does that sound familiar, feeling well rested. Hello, everybody. My name is Rob Basil. I'm the Executive Director of Metropolitan Center for Mental Health. We're a nonprofit up in Upper Manhattan in New York City, and we've been around a long time, for about 70 years. And we're a comprehensive outpatient behavioral health center, so we do everything you can do on the outpatient basis in both mental health and substance use across the lifespan, children, adults, older adults. We have multiple locations, multiple programs that are regulated by different regulators in New York State. Mental health and substance use, it's separated in New York. We're in schools, and then we have freestanding outpatient clinics. Our why, we share some similar elements in our story to what I think others have said. Our why began years ago when we were seeking to make an EHR change. When we started to think about becoming more data driven in our services and starting to think about what are the right outcomes we want to develop, and establish strategies on how to collect data to establish them. We started working in our existing EHR and found some limitations. So that led us on a search, for other reasons as well, to look for another EHR. That led to an implementation of a new EHR, which is a big to-do, as we all know. We did that, we embarked on that about 3 or 4 years ago, but we quickly came to learn that even though you get a better EHR, you still got to do a lot of the work yourselves because no EHR sort of has all the tools that you're looking for. And we needed some experts and to help us along in actualizing our strategy. So we started looking at ways in which we could, like others have said, get all of our data centralized into one source. Quite frankly, when I first met Alex and Rich at 5E, I don't know, a year and a half ago or so, probably one of the newer clients to 5E in this bunch, it had not quite synced in our thinking that how powerful having one data source could be, how powerful having a data lake, and the degree to which you could bring in all the different data sources that we were trying to establish outcomes and data strategies and analytics in silos. So once that conversation happened, that quickly put us on the path of seeking to work with 5E. So what we're working on, our goal is to, like others have said, is to bring analytics to all aspects of our organization. And our connectors, for instance, there are a couple of EHRs in there. There's our legacy EHR, there's our existing EHR. There's mandated reporting that we have to do to the state. That's the OASIS in there. We have a separate billing service that holds all of our claim data for our revenue. So bringing all these into once, and not mentioned in there is also our HRIS system, which is a future goal. So that concept of bringing everything into one data source is essential to being able to really not just streamline, but I think be as efficient as possible, and to bring the whole organization together in that strategy. What makes our data unique? One thing I can say is that because we're such a provider-rich organization, we have upwards of 120 individual providers at all disciplines, and they work all different hours, employees and non-employees, and we have a lot of per diem staff, and to be able to create productivity reports and dashboards for each provider is quite a to-do. And to be able to establish our methods of payroll, we have a number of different payroll systems. To be able to do that, we were doing a lot of that stuff manually and doing it through different systems. And after working with 5E, essentially we developed a strategy where we can have that all come together in one source and create dashboards and reports for all of that, so that can be so efficient and can corral everything together. So I think putting that in one source has been real effective for us.
I think that's going to end up being a pretty distinct theme for the day, the concept of bringing everything into one place. It's definitely a challenge that we've seen with providers of all types, no matter what kind of service lines that you have. Giving one place to go for all those different reports that help keep the lights on is really the goal. Just a little bit about 5E. We like to think of ourselves as anything data. We love to work with providers, whether it is building dashboards, helping with things like data engineering, moving data back and forth, transforming it, removing some of those manual processes that take a lot of time during your month, where it usually is going to result in a mission critical report that you need to use to operate. We like to work with the clients around data governance, being that data steward, like Rochelle had mentioned. How does everybody see the data? Does everybody agree on the terms, on the metrics? And we'll talk a little bit about that in a second. We do all that through a combination of proprietary tools, starting really with our ETL process. You'll hear us use the data lake a little bit today, and we'll talk about some of that in detail. But really what we found is there's 5 major categories of challenges that providers tend to have. And what we wanted to do for the webinar today is talk about some of those challenges and some of the solutions that we like to share with our clients to help allow you to really be that data-driven organization, even if your example is a little bit nuanced compared to somebody else's. Categorically, people tend to fall into these similar categories where this challenge helps or ends up reducing the amount of efficiency, adding to staff time and requiring a lot of that manual effort. We see these 5 categories of data integration, kind of moving information back and forth between the systems, having things be decentralized, the inability to really monitor and continuously change who's in charge of defining what that data means, and making sure that gets to everybody from an oversight perspective. Data quality is a very simple term, but it can have a lot of different meanings, and it can lead to a lot of different challenges. And what we have found is the solutions to these fall into the 5 C's that we refer to. We'd love to do it as the 7 C's so we can have a pirate-themed logo here, but 5 is really what it comes down to. So we're going to be sharing some relevant examples from the providers that have introduced themselves so that this is not a theoretical or conceptual presentation. We want to share with you real life kind of scenarios that people are facing. We'll talk about all of these things individually, but for anybody who might want to look through the presentation after the fact, I wanted to have them all defined here in kind of one place. We might take these in a bit of an out of order kind of approach, but we're going to make sure to touch on all of them. Before we jump into our first one, I wanted to give Alex a chance to introduce himself, and then we'll jump right into it.
Thanks, Rich. So I'm the CEO for 5E Analytics. I'm very grateful to our clients who are doing this webinar. And just to let everybody know, this is really, for me, I'm looking to have our clients act as kind of like educators for the space. So the things that I know from bringing things from banking and retail of how data gets moved, how we can get to data science, how we can do deep analytics, bring it to the behavioral health, substance abuse groups, because, and you'll hear me use this term occasionally, is if Amazon can know what you want to buy before you can buy it or before you decide to buy it, we should be able to provide the same types of technologies to help mental health, substance abuse programs. So thank you.
Excellent. So we are going to go a little out of order, like I mentioned, and I wanted to start with commonality. What this really comes down to is being able to reach an agreement on what data means, whether that's an individual field or it could be a metric, a performance indicator that you're kind of working towards, and making sure that everybody is marching to the beat of the same drum. What we find is this ends up being a kind of continuous process. It needs to be consistently reviewed, whether that is more of a discussion or a debate or an argument. And a lot of times it includes not only internal resources, but how other people externally view a certain metric. So I wanted to start by kind of asking the group here, what does successful outcome mean to you? And I think what we'll find is there's really not an easy way to define it, but I'd love to know, maybe we'll start with Rochelle. I'd used permanency as your example. What you deal with when it comes to how to define such an important thing.
What we have found is that what we as an agency consider a successful outcome may be different than what our state considers successful. For example, if a client is discharged to positive permanency, for us, it could be maybe they're 18, they've aged out of care, but they go directly to college enrollment. To us, that is successful. However, in at least one of our states, this doesn't count as a positive outcome. In this state, they only consider family reunification and or adoption as a successful outcome. So when evaluating our outcome data, we need to consider 2 perspectives: the criteria for success established by the state and the benchmarks that we set internally as an agency.
I think it's probably pretty similar from Amy's perspective, given the size and scope of the programs at Welllife. Outcomes got to mean a million different things, and it might even change year by year.
Absolutely. And depending on the state of, Overwatch, whether it's OMH or OASIS or the DOH, because we have care coordination programs as well, their metrics for defining what a positive outcome can be very different from our organizational outcomes. And again, it can vary from grant to grant as well. So, I mean, I look at success as engagement and retention for both staff and the population that we provide services for, whereas other regulatory bodies might be looking at different things. So we have to have the balance between meeting those state standards as well as our own internal goals.
What an interesting kind of relevant example with the staff retention piece. You know, I think naturally your mind for outcomes goes to clients, but outcomes are results for the organization too. And in order to deliver the care that you're doing for all these clients across all these programs, all these service settings, got to have somebody to deliver it. So it's another thing you have to keep a close eye on.
Absolutely.
I'm sure, Rob, you're dealing with similar regulatory oversight that Amy is dealing with too, huh?
That is true. I love how everyone's talking about how outcomes are determined for us, whether it's, you know, a grant or whether it's a an oversight body or CMS for that matter, you know, whatever it might be. And not to throw out those metrics at all, right? Some of them actually are quite valuable. But there is very much a difference between an organization's goal and the organization. So for us, for instance, we're so patient-centric, we're people-focused, that for us, I think one thing to add to this conversation about what defines an outcome for us is that it's at the end of the day, it's going to have a positive impact or effect on the people we serve or the people who are serving them. I mean, Amy brought up that point. So I could bring up two examples, for instance. So if we have an outcome that we think is a measure of productivity or is a measure of service quality, it does no good if it doesn't translate to patient satisfaction, patient improvement. So if we are able to link outcomes to as close as possible to patient improvement, that's a way of doing it. On the staff side, our staff works hard, and we're always looking at efficiencies, how to create efficiencies and workflows and so forth. And one example is we're all trying to improve access, right? So as we're trying to improve access as defined between when someone calls us for an appointment and when they get assigned to treatment, what's that measure of time? We're all trying to work on, that's a big metric. Being able to reduce that is going to be satisfactory to the patient in improving access, but it's also going to help our staff to be able to, if we use that as an outcome, our staff to be able to feel that they can do their job more efficiently and be rewarded for it. So I think if outcomes can be people focused and really get down to helping people out, whether it's the people who are serving or the people that are getting served, you ultimately got to define it that way.
What do you think, Leanne?
Well, so as a substance use agency, recovery is typically our biggest goal, right? For an individual to be able to sustain long-term recovery, but everyone's recovery journey is different. So someone may be looking to maybe reduce their substance use versus to abstain long-term abstinence. But harm reduction is also something that we're working with individuals on too. So if somebody is looking to maybe drink alcohol 3 times a week instead of 6 or 7 times a week, that's something that we're trying to help them with as well, instead of just a zero tolerance, which is something that we were doing 10 or 15 years ago. So I think in terms of a successful outcome, it's really just helping the individual, like Rob was saying, helping we're patient-centered. So it's really helping the individual on what their goals are. And in terms of wellness and improved PHQ-9. So maybe an individual doesn't reach 100% abstinence, but maybe we've increased their wellness by maybe they're eating better, maybe they're exercising, maybe we've improved their PHQ-9 score. So, recovery is kind of a broad goal to work towards.
I think the example that always comes to my mind when I'm explaining kind of the behavioral health in general to people who are from outside of the industry is, it's easy to say that if you've broken your arm, at some point your arm isn't broken anymore. But there's this concept of like better but not well. And it's hard to define some of those things. So it's kind of this constant iterative process of having those discussions and arguments and figuring out how you can use the data to back up your story. Alex, I know we've talked a lot about some of these, and it's funny when Rob was talking about the access component, something that it reminded me of the CCBHC data and that kind of first contact. And what does that really mean? It's not supremely well defined by CMS because it could mean a lot of things. I know that you had a ton of examples that you can share about commonality from different industries too. Anything come to mind?
Just the big one from health insurance where the concept of a paid claim. You can get one person say a paid claim for the insurance company is an adjudicated claim, or the CFO says a paid claim is no, I actually spend a penny on the claim. And it's important to understand that those will affect all of your reports if you don't get the definitions correct. You can create multiple definitions, but this way, this commonality will express the entire context of the organization properly so that everybody's speaking the same language.
And sometimes it ends up being multiple perspectives.
Mhm.
All right, so the next one that we're going to dive into is centrality. Like I mentioned at the beginning, I think this is going to be a theme. We always like to talk about this as we start to meet new providers because it ends up solving a lot of problems and ultimately gives you a lot of freedom. So if you look at the left side of this diagram, when we talk about ETL, the extract, transform, and load, by pulling that data into one place, usually nightly. Amy, I know in your case, we have some examples where that data needs to be more frequent, even 15 minutes. But pulling it out of the system reduces your reliance on some of those stock reports. Not that they're bad, not that they're not a useful thing for people who are operating day to day, but being able to absorb all of that information and have the ability to transform it in an automated way theoretically removes all that dirty work, all that kind of manual manipulation that has to happen a lot. Alex, I'd love it if you could maybe, from more of the academic perspective, explain the difference between a data lake and a data warehouse.
Well, the biggest difference is the data lake is really the raw data coming from the systems of record. And a data warehouse is usually some sort of optimized structure or detailed structure for given systems. So the biggest difference becomes you're going to move your data into the data lake, which used to be called an operational data store, the data as is, and then it gets moved into some other structure so that you can do reporting faster, because it's not always the case that you can report from your systems of record faster. The key here is once it gets into a data lake in its raw format, you can then transform it however you want and push it wherever you want for integration with other systems or additional reporting or the advanced analytics without ever touching the systems of record or even relying on the systems of record in terms of producing a report that takes 15, 20, 30 minutes to run, and you're waiting, you actually have the data available.
I also like the idea that it brings it all together so that every output ends up being synchronized. Everybody's kind of looking at the same format. So it's removing the ability to argue that I think this one's right versus this one's right. If it's all coming from the same place, you know that you're synchronized. One of the great examples of centrality and the benefit of it really comes into play when we talk about your audit and compliance needs, Rochelle. You want to talk through some of this? I know we briefly talked about it during your intro, but I think just a totally key part of the puzzle for a lot of providers these days.
Yes, of course. So as I'm sure everybody on this call goes through this, you constantly are receiving requests for your data from courts. It might be subpoenaed. It might be an audit, and they're ongoing. What we have seen is that most of our compliance inquiries that we receive from the courts pertain to our older records that were in our sunset system, which is KaleidoCare. So utilizing the Memphi audit and compliance tool, and of course the awesome team of 5E, we can ensure that we can provide subpoenaed records as required by judges and auditors, and we get it very quickly, very quick turnaround. And one of the things that, and I explained this to a lot of the people that I work with, when we received our KaleidoCare data, it's all in SQL code. So it needed to be, as I put it, translated. And so that's what the team at 5E and the Memphi audit and compliance tool has really helped us with, so that when we get those requests for a subpoenaed record, we're not trying to send the judge something that they can't read. It has to be in a readable format in what we call human language. And this tool has really been a lifesaver for us as it relates to that.
As much fun as it would be to send something indecipherable sometimes, the reality of it is it would create more work for you and your team.
Yes.
So I think it's a very common challenge these days. I think yours is a particularly unique situation with 26 years of data in that old system. But at this point, everybody is on their usually second, third, or fourth, or maybe even fifth EHR. And as your needs change operationally for how you capture the data, different systems are going to be the right fit at the time. But the old data, whether it's for a record retention law or simply for some of the other advantages it will have by having everything kind of consolidated, you have to, like you said, translate, map those things together in the background, because what you want to be able to say is, I need the most recent treatment plan, placements for this child over a date range, all the notes, so that the system can go get it no matter where it was originally captured. And those things need to basically say the same thing. I think from a centrality perspective, it can be all data from the EHR, like we're talking about here, or in your case, Amy, really something that's a constant struggle to make happen on a monthly basis. And it's a mission critical report that you need to use to operate Welllife.
This is very true. And this was to do the 835 reports for the CFO. This was a laborious process that actually my engineer was doing for the last 2 years, which is why he wanted to quit. But thankfully, now, you know, 5E took that over. Kara, she's not allowed to go on vacation ever. Which
I
happened
second
last
that.
week, yes, which happened last week, and they had to do it manually. But just eliminating that manual process, now it's something that is, you know, takes a couple minutes rather than hours worth of work to format the file the way the CFO wants to see it, because she will not use a dashboard.
Yeah, it's interesting how all those things come together too, because some of them are your systems and some of them are not. So
Yes.
it's really combining everything in one place that you may or may not have had the option to kind of manually pull some things, which is a real challenge and just doesn't make anybody's lives easier. Alex, before we move on to the next concept, anything you would want to add from a centrality perspective?
Well, I think just the bigger one is when we first started this project, I think it took, if I'm not mistaken, somewhere between 12 and 16 hours to process all of the data in preparation for you to do what you needed to do out of NetSmart. And like you said, Amy, it's all in minutes because all the data is now centralized. It's being pulled in every day, so you don't have to worry about any other pulls. It handles it and creates what you're looking for.
Absolutely. And I love how horrified every time you hear what one of our processes are, you know, that is, your reaction is what I was looking for, you know, so I enjoyed that. You know, when I say things like crystal reports and you're like,
Alex loves crystal reports.
Right.
All right, so then the next concept is connectivity. It shares some common components to centrality, but really it's the ability to allow data to move back and forth between all of the different systems that you use to operate the organization. While it has to take a pit stop in that data lake in most cases, the ability to kind of exchange data allows you to remove a lot of opportunities for errors. It helps you identify where that source of truth is. If you have two fields captured in different ways, which one's more right than the other? And more often than not, rather than take the chance for that error to happen over and over again, just have one fill in the other, even if that means removing the ability for a human to add to that field. It allows you to reduce that manual effort of manipulating it all, comparing it together and cross-referencing it. And when we talk about the data lake as one of our major virtues, we want everybody to think big. It's natural to kind of begin with the EHR. That's going to be the most broad system that you capture all of the different things from the administrative, clinical, and billing perspectives of your organization. But as we've already discussed, it really isn't the extent of it. You know, this is also going to get into your hiring processes. How are you credentialing your staff? When you have recruitment for foster parents, which might require the use of the website to get people to know where to sign up, where to say they want to learn more information. And then ultimately, how does it end up back in that 835? What happens to that data when it comes back in? And that's more often than not going off to financial software in some case. So when we talk about the data lake, it is one, pulling it all into one place, but it also gives you the freedom to push it out to other places too. Rochelle, I know we've talked about this a whole lot this year, but it's really kind of an interesting use of the tool from my perspective because it takes into account so many different places where you'd have to go pull something out manually and hope to mix it all up and come out with the answer on the other side. Can you talk a little bit about the recruitment process from the website?
Yeah. So we encounter challenges with the data integration, particularly with our recruitment leads. Um, we have leads coming in from different places, Instapage, our Omni website, through WordPress. And what the use of Memphi has done is streamline this process by consolidating all of our leads that come in from the website, Facebook pages, and other sources into that one single location. And that enables us to access lead information in real time by state, program, staff. We can easily track productivity, and that also enhances accountability. And we can ensure that we are actually maximizing our efforts to license our high quality homes.
And it also allows you to send that data back into the EHR where kind of everything
Yes.
ends up being worked.
Yep.
I thought it was really interesting when we first started talking about this, that to have that inquiry form where it was just slightly a different domain than the Omni website, there's an interesting kind of, I don't even know the right word, but when people are looking to get more information about something, every little step of the way, every click needs to look the same, needs to feel like I'm not deviating from the path that's been laid for me. And by kind of just pulling that information in from the website or from the landing pages, it removes your need to manually enter all those things.
Yes.
But it also makes sure nothing slips through the cracks, which I think is a real kind of fundamental component of connectivity. And it all again starts with that data lake. Amy, from your side, I realized that we were going to need some bigger smart art options because of all the different systems that you guys are using and pulling in. When it comes to connectivity, I think the WellLife team has kind of interesting differences. You break things down from an IT perspective, some of these things that happen behind the scenes that sometimes it doesn't even look like it's happening, but ultimately it's keeping things synchronized. From the clinical side, I know we're diving into some of these projects a little bit on the newer kind of side of things, but when you're dealing with the HealthX or those pass forms or the new appointment reminder system, having it all in one place lets you do a lot. You want to talk through what that process looks like from a human perspective?
Well, for many years, we were signing consent, having our individuals who were receiving services sign consent for HealthX, and clinically, we were never receiving the data in the programs. And once I took over this role, I asked my team, where does that data go? They all looked at each other. Finally, we figured out that it was on an SFTP server in these daily files that had been accumulating for the last 2 years. And that was interesting because that's data I would have loved to have had. So it became what are we going to do with it now? And my team looked horrified because they didn't want me to tell them that they had to parse it out to the programs. So we met with 5E, and Kara said, sure, no problem, which was the answer I wanted. And now daily alerts go out based on the programs to the right program contacts every single morning with those hospital alerts. So clinically they can intervene. I mean, it just makes more sense. With the pass forms for OASIS, the OASIS programs know about these and have filled out many of them in New York. This was a manual process for us for many, many years. Even though OASIS had the interface for the batch upload, we never utilized it. And now that we have those forms electronic, because I built all of them, and all the check boxes that go along with them, that was in SQL queries, which was awful. Now
You said you had so much fun and you would want to do it again, hopefully next year.
Yeah, I think I quit like 3 times that week. But now Karen and Sam are working on the batch uploads. So this way it doesn't have to be manually entered by one of the receptionists anymore. And our newest venture that we are going to be starting in 2024, it's about time, is text message appointment reminders. So I know I rely on them to know that I have an appointment somewhere. So why would that not help our population? So we are working on that. And yeah, Kara, we're going to have a little meeting about that. Send you an email.
Now that's another system outside of the EHR, yeah?
Correct, correct. So that's an outside vendor. They do not have an API. They have no way of automating this process for us. They would require us to provide them with a daily CSV file. And I have 4 people on my team and we manage about 11 applications, so we don't have the hands. So that's, why I say, hey, Kara, just, be a magician and just make that happen. I don't know what she does. She just makes it happen. I'm like, oh, okay, great.
With a
It's
little help,
magic.
say it here.
Yeah, it's magical. I don't need to know the details.
Now, Alex, from the IT side of things, always some interesting kind of synchronization that has to happen. Talk through the left side of this diagram.
Yeah, so pretty much what happens is that for WellLife, when there's an onboarding that occurs in Paycom, that information actually gets pulled into the data lake, and then there are processes that will actually create the account in Relias, as well as check to see if a record was created in their Active Directory. The key thing is when you have a lot of operational flows from an IT perspective, you want to be able to match and query and say, is there a record here? Is there not a record here? Push this record and so forth. That helps streamline the process, but more importantly, it identifies gaps within the process. It identifies where there's certain things maybe falling by the wayside, and you can then remediate them.
And Amy, I'm sure you would feel there's always room for improvement here because there are some annoying processes that have to happen manually, but there's always a way to start looking deeper.
Absolutely. And the IT side of things is the other half of my department. So they are handling the AD and my team handles the HRs.
Just a couple applications, just 11.
Just a few things. We're not busy.
I think it seems so basic to talk about data quality. Alex, we talked a little bit about that paid claim example, but Leanne, I think your example here is really interesting where there's a million different ways to configure an EHR, and everybody's workflows are going to be a little bit different, especially when you start mixing in different service settings. It's really interesting to me that all groups on this call, everybody has community-based services, residential services, things that happen in home, things that happen wherever the client may be. And those processes can be kind of challenging. And it's hard to define some of those things over time. So we already talked a little bit about that kind of what's the clarity look like around an outcome, but it really does apply to a variety of different things. It also is a way for you to be able to define which system has the right information when you need it. If we go back to that access example for CCBHC, does it start with a third-party voice conferencing system when you get that first call? Does it happen to be the first time somebody clicks on the website and says, I'd like to request more information about services? But having these conversations and making sure that you're able to cross-reference that data without having to take things on a weekly or monthly basis really saves a whole lot of time and makes sure you're more and more accurate. Rob, I know this payroll report is a really complicated process. Knowing that we're a little shorter on time than I want it to be by now, I wonder if you can maybe give me just an overview of what it used to look like and how things have changed.
It used to be so heavily manualized, and we used to have a couple of key people working on it. And when turnover hit, we were in a quite a pinch. So this goes way back. Essentially, we have a large number of per diem staff, and they all get paid in different ways based on service type, based on appointment completion, based on hours, and all that data. So there are different data points for each per diem staff, depending on the department that they're working in, So psychiatry, nursing, or, psychotherapy. So the reporting to determine payroll is developed in lots of different ways, in numerous ways. We were doing this manually for so many years, and then we moved into using Tableau to help us assist with that. And while that improved things, we're still doing hours of work, and creating reports out of Tableau and dashboards out of that. And it was still a bear. And the main thing was this tied us up, like other people have spoken about. This tied up our team in focusing on this. This was the first thing we brought to 5E. We brought this to 5E and said, we've got to tackle this before we can really look at dashboards for productivity in any kind of way. And within the first month of being contracted with 5E, and it's now in Memphis, it's automated, and that all that manual process and time that we used to spend for years and years has essentially been eliminated. And when we check the reports, they're accurate, and we haven't had any complaints from anyone in terms of the accuracy of it. We double check it, and so it's been a lifesaver, and it's taken something that's just been a bear that we just assumed would be a cross that we've been carrying for a long period of time because of the sort of nuanced way in which we pay people. That is now solved, and now we can focus our resources in other areas.
There's probably such a number of things those resources could be doing otherwise, right? Always more work to do. Leanne, with your census, it's kind of the same scenario, right? It's finding a way to get outside of the boundaries of what stock reports look like out of a single transactional system.
Yeah, so like I was mentioning earlier, so for those that are familiar with the 820 residential model of care, there are 3 levels of care. So in our EHR, the way that our system has the program histories is that each level of care is its own program history. So if I have an individual that is in element 1 stabilization level of care, when they step down to element 2, it tracks it as a discharge. So even though, yes, they're technically completing the level of care of stabilization, they're not discharging from our program. They're just stepping down to the next level of care, or vice versa. If they're in element 2 stepping up, they're stepping up to the level of care. So our current EHR is unable to differentiate that this individual is just stepping up or stepping down. They're not discharging. So thankfully, 5E has been able to help us determine what is a step up or step down versus an actual discharge. So again, like Rob was saying, and our other colleagues were saying, that what I was doing manually, I was going into our EHR running manual reports, and I would have to see that the disposition of the discharge was actually a step down versus an actual discharge. So we're able to actually, I have many census dashboards, thank you, Karen, Chris, that you guys have worked on over the years, that we can accurately not only track what the current census is, but, discharge reasons and trends, clinical outcomes, things like that. So it's just been a lifesaver of time.
And sometimes it's just about looking at that data slightly differently, right?
Right.
Kind of feeds right into this last major concept of control, which is you need the ability to collect it in unique ways because the data you're collecting is often unique. Taking it through manipulation, transformation, or cleansing process is just kind of the next step, the next stage of that, which is how do you need to see it? How does it allow you to make decisions, even if it's a little different than what your EHR might see as their way of looking at it. We always like to talk about this concept of data governance is not an IT initiative, but it's a consistent communication about what we care about, how can we make sure it's accurate, how can we make sure it's easily digestible, and that can take many different forms. Leanne, I know, I'm so sorry, we are running a little low on time, so I'm trying to go a little fast here. But we talk about the aftercare program and some of the challenges for what you need to track against that grant.
Yeah, sure. So, so we have a current grant that we're providing aftercare follow-up services for, and I've been working with 5E to create a dashboard for it so that we can track the data for the services that we're providing, so that we can hopefully provide that data to, whether it be OASIS or other governing body one day, to ask for funding to be able to, hopefully be able to get funding for it when the grant is exhausted. So we do have a dashboard currently that we're able to track, trends for the services that we're providing in the aftercare program.
I love the idea of the alerts here, where it's what can the data actually do to drive your workflow, rather than how can you look at it and interpret it a certain way, but have it start at the data and kind of end there too. Rob, I know you're going through some big old changes with bringing everything together in one place, but I think kind of the empowerment that you feel is what I thought was most interesting about our conversation leading up to this. Can you tell us a little bit about your experience?
Sure, and I know we're low on time. I like hearing everybody else's stories too about where they've come in their journey and what they've been able to accomplish. It's you said think big, Rich, and you told me that when in the early days when I met you. But hearing people's stories, it helps you really think about the power of what you can do with all the data that you have, and you're not even thinking about where you and all the different sources. But that's our the idea of feeling empowered by having control of your data. I mean, we have legacy data in systems that are not active anymore, and they are and being able to pull them all into one source and then run analyses out of that source is just I can't tell you how invaluable that is. But beyond that, every data is defined in different ways in each of those different systems, and be able to pull them in and create analyses that pull from multiple systems. We have long-term patients as an example, and that patient may have data in one in our legacy EHR versus our active EHR. And we want to be able to look at an outcome that crosses both systems. To be able to do that through Memphi is and design that in Memphi is just invaluable. And that's not something that we had really thought would be set our eyes on the possibilities for. So and then as of course, as Rochelle had talked about before, I have different people who have who hold access to different systems based on their super user expertise from being here at the time. And to be able to pull it into one source, now we could have our records department, right? Go to one source, and we can train in that one source and pull records out of that source. And yes, it can be sort of digestible and sensible when we pull it out of that. So that's just I can't imagine how any organization wouldn't need that after being working in healthcare for any significant period of time. It's just to know, yeah.
I even think, just the movement between EHRs and how often you all get requested for records, it's just something that's a constant burden. Having it all in one place, especially if it's standardized, it's just a different conversation and a different amount of freedom. I'm going to actually jump forward a little bit. Alex, I'd love for you to talk a little bit more about what you had said earlier, how we bring some of this to the forefront for providers.
Yeah, so I'll take 30 seconds for this. So other companies like Amazon, banks, other retail organizations have been leveraging data for decades. And the more data they collect, the more they can tell about their customers, about the environment, the economic environment, their product, services, everything. The key is that by having all that data centralized, by being able to pull in information in different formats, because not every system will allow you to pull the data direct SQL connection, or maybe it's an API or something else. And we try and figure out ways to get that data. We have a lot of connectors to do that. That puts the power in your hands and then enables you to do more predictive analytics, more advanced analytics with regards to things like classifications, prediction, and even text analysis, sentiment analysis, which we're doing for some of our clients.
And I think, we're the new buzzword of AI is floating around behavioral health. It's a little bit on everybody's minds. And there's a lot of purpose-built applications to simplify certain things. And usually it's aimed at a reduction in time spent collecting data. But don't forget about all the things that you have already in the different systems that you use that you can use to do things like revenue prediction. What about staffing? How many staff will you need based on the amount of client growth this time next year? Looking at risk classification between clients. And how can you get some early warning signs about whether or not a client is aimed at a successful outcome, and then taking advantage of all the text fields. You think about the EHRs alone, how much of those databases are comprised of the narratives, and there's value in it, even though it might be hard to see sometimes. Wanted to share a little bit about some of these examples. Rochelle, I know we've talked about this one a lot this year too, how you're looking at incidents.
Yes, thanks. As I mentioned previously, we've had over 25 years of data in our Sunset EHR, and we aim to shift our focus towards understanding what that data can tell us. Can it help us mitigate risks? So this slide illustrates insights from our incident data. So just to give you a background, Tier 1 is a very low incident, most likely not reportable to the state, and Tier 4 level is a fatality. What we found is that, as you can see, males are more likely than females to have a Tier 3 or Tier 4 incident. But we also found that kiddos with a higher count of Tier 2 incidents are less likely to experience a Tier 3 or Tier 4. So I would say that the most impactful thing that our data revealed is that our interventions are directly correlated with preventing higher tiered incidents.
And we talk about the kind of the yin yang of analytics a lot. And I think that's a really powerful argument to make, whether it's to a regulator, funder, even a new grant. Leanne, I know you guys dealt with something similar as you moved from 819 to 820.
Yeah, so over the last 6-7 years or so, we have converted our residential programs from 819 to an 820 program, and we looked at the changes and the treatment outcomes, and I won't go through all of them for time, but I'll just make mention that a couple of the big takeaways is that, you know, in the 820 programs, that an individual is 20% more likely to result in a successful discharge. I would say that in the 820 programs, there's more qualified staffing than in 819. That means that there are more CASAC, social workers, LMHCs, LPNs, RNs, psych NPs, also more evidence-based practices and groups being served. And then also just make mention that individuals are 3.5 times less likely to result in criminal justice withdrawal. As most of you probably know, there's also been a lot more treatment courts that have been used in the state of New York over the last 5 to 10 years as well. So I'm sure there's a big correlation there. But yeah, so just a lot of great data that we've been able to use with the help of 5E to be able to just track trends.
I think it's a difference of opinion versus some factual arguments. You can take this and show the data or the story that the data tells, which is just incredibly powerful.
Yeah.
I definitely went, we were a little short on time, and I'm sorry, I knew we'd be close, but I wanted to end on this slide. It's something that we feel very, very strongly about, that when it comes to, you know, looking forward and going beyond and doing more things with your data. We've talked a lot about the centrality components, bringing things into a consolidated place. It lays the foundation for you to do very interesting things and take out some of that subjectivity so that you can make a stronger argument. We always recommend that you focus on this bus analogy, but be brave. Don't be afraid to think big, Rob. Unlimited, don't hold yourself back. Do we have the data for that? Do we have enough of the data for that? There's always information and insight that you can kind of pull out of it. But also be specific and say, here's the question that we want to answer, and let's find a way to prove our point or to know that we're barking up the wrong tree. So I know that we're out of time, but I wanted to thank everybody again. Thank you to our panel for everybody joining. We would love to do some more of these, and I will send a survey around to see if anybody is particularly interested in doing that on a quarterly or monthly basis. But thank you all for joining us, and we'll see you next time.
Thank you.
Thank you.
Thanks.